Good.
Okay, well, welcome everyone to Geriatric and Palliative Medicine combined grand rounds. We have about 4 of these sessions each year. And so it's a combined geriatric medicine and palliative medicine topic. And as we all know, both specialties seek to really figure out patients and their families' values and goals, and then align treatment to those values and goals. And so I am really honored that Dr. Dan Lamb accepted my invitation, where I begged him to come speak to our group, our division, because he is in high demand for his expertise in not only nephrology and kidney disease, but also palliative medicine and palliative care. He did his fellowship here with us at the University of Washington and is a graduate of our program, as well as in nephrology. He did his nephrology fellowship here at the University of Washington as well. And I have relied heavily on him for his expertise in concurrent care, where patients receive both hospice and dialysis. And I have been very grateful for Dr. Lamb, and again, just, his care of particularly our challenging Harborview patients as well, who often fall into those categories of kind of wanting to continue dialysis, but also wanting to pursue care that speaks towards their comfort and quality of life and symptom control. So again, just very grateful to you, Dan, for accepting this invitation and coming to speak to our group. And without further ado, I'm just going to let you take it away.
Well, thanks so much, Annie. That's very kind of you to say all of that. It's wonderful to be here this morning. The title of my talk is, Can Hospice and Dialysis Exist Together? Addressing Disparities in End-Stage Kidney Disease Hospice Access. Many of you know that I've been working on increasing access to hospice for dialysis patients for some time. And in fact, I've collaborated with many of you, and I think many of you have also collaborated with my teammates through the kidney palliative care team at Northwest Kidney Centers. And so I'm very, very grateful to all of you for that. These are my disclosures. I consult for Vinca Care. This is my outline. I'll be talking a little bit about the history of the Medicare hospice benefit. And I'm sure many of you may know a lot more about the background history of this than I. Talk a little bit about who receives hospice, who receives dialysis. We'll look at it a bit from the lens of sort of the audience here, as well as from the standpoint of disparities. Hospice access for the end-stage kidney disease population. Some forays into concurrent care outside of end-stage kidney disease, and then concurrent care for patients with end-stage kidney disease. Let's start off with a case. I want to introduce you to Rabbi Morton, and I have permission from his family to share this. He is affectionately known as Morty. And yes, he was a patient, and yes, he did have kidney disease, and he was on dialysis. Yes, he also received concurrent care, hospice, and dialysis at the same time. But before I give you his one-liner, he was also a devoted teacher and husband, a mentor to many, and a student of life. And when I met him, Morty was an 85-year-old man with multimorbidity and frailty, cognitive impairment. And he also had end-stage kidney disease secondary to diabetic kidney disease. He was on dialysis for a little over 3 years at this point. He had significant cardiac disease, including multivessel coronary artery disease, multiple PCIs, and had just actually suffered a pretty significant inferior ST elevation MI from a recurrent RCA lesion. And his primary nephrologist, who had known him for years, guided him and his wife through primary palliative care conversations. They'd gone through advanced care planning, had discussed whether or not he would move forward with dialysis. And the themes of these conversations really set the stage for the referral to me and my teammates at Northwest Kidney Centers through our kidney palliative care team for further goals of care conversations. And he and his wife really hoped to maximize his time at home together. And he had been tolerating dialysis actually relatively well, all things considered, given his age and frailty and comorbidities. And so we will pick up his case towards the end. So let's talk a little bit about the history of the Medicare hospice benefit. So I think many of you know Dame Cicely Saunders, who founded the first modern hospice in 1967 at St. Christopher's in London. And she addressed the significant gap in medicine at the time, and arguably there still remains that gap still remains to some degree today, and the care for patients who really no longer had a curative option. And she emphasized that there was much caring to be done, not only in terms of physical symptom management, but also attending to the emotional, spiritual, and existential needs of the patient. And I love this quote from her. You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. Interestingly, there wasn't sort of this delineation that people could not receive chemotherapy, for example, when they received sort of hospice services. Most of them did not, but St. Christopher's also cared for patients who received sort of concurrent care, so to speak. So kind of fast forward to the Medicare hospice benefit, which was passed in 1982. I've been a hospice demonstration project just prior to this that had allowed for concurrent chemotherapy in the cancer population. And so you may know a couple of these characters here. The Medicare hospice benefit was sponsored by then Representative Leon Panetta and Senator Bob Dole. And you may then be asking, so, where did the 6 months come from in terms of sort of prognostic eligibility criteria? During these negotiations, the budget director for the Reagan administration insisted that Medicare should not pay for simultaneous curative and hospice services because the cost would be too high. And so that was just part of the negotiation in order for the Medicare hospice benefit to pass. And so when it passed in 1982, that's where we get our prognosis of less than 6 months. Who receives hospice? I think this will set the stage for some of the disparities that we see in the end-stage kidney disease population. This is data that's taken from NHPCO, looking at Medicare decedents who receive 1 or more days of hospice care. There are about 1.5 million Medicare beneficiaries in 2018, and 61% of them were older than the age of 75. So about half of people receive hospice, at least 1 day of hospice. And when you kind of drill down a little deeper into sort of who else receives hospice, it's primarily white, 82% white, 8.2% African American, 6.7% Latinx, and 1.8% Asian Pacific Islander. A little bit more female than male, and you can see sort of the age breakdown here. So about a third are 85 and older. And just to kind of put it into context, this is data that's taken from the US Census Bureau regarding sort of the general US population. So as you can see here, all minoritized communities are underrepresented in terms of usage of hospice care and overrepresented in terms of white Americans accessing hospice. So how long do people receive hospice care? And this has been durable actually for a number of years now. The median length of stay has been 18 days, and that has stayed static for some time. But you can see there's quite the range. In fact, I think this bar here kind of jumps out to me that still we have about almost 30% of people accessing hospice for about a week or less. And of course, there is quite a spread. So about 14% of people are on hospice for more than 3 months. So about who receives dialysis? So this is a prevalent count of end-stage kidney disease from the year 2000 all the way to 2020. the prevalence has approximately doubled from about 400,000 to about 800,000 in 2020. In fact, the prevalence decreased slightly from 2019 to 2020, and this is the first decrease recorded ever by the USRDS, which is the sort of the dialysis database. And this is the prevalent count of end-stage kidney disease by modality. So about 60% of patients are in-center hemodialysis in this blue line, and that's about close to 500,000 patients in the United States. 30% have received a transplant, 8% are on peritoneal dialysis, and about 1.5% on home hemodialysis. This may be of interest to this group here, looking at the prevalence among older individuals with end-stage kidney disease from 2000 to 2020. And so this is cases per million persons. And the prevalence is highest amongst older individuals consistently compared to younger individuals. So the blue line here, 75 and older, the green line, 65 to 74. And then the incidence of end-stage kidney disease by age, again, the oldest age groups have the highest incidence, although this has been declining somewhat over time. So there are about 130,000 patients with newly diagnosed end-stage kidney disease over the last several years. And looking at race and ethnicity, the makeup of the end-stage kidney disease population is disproportionately Black and brown. The prevalent end-stage kidney disease population is about 35% Black, here in the red line. African Americans are 3 times as likely, and Latinx patients are 1.3 times as likely to have kidney failure compared to white Americans. So here down in the blue is the sort of white prevalence of end-stage kidney disease. Here green is Asian, Hispanic or Latinx in the gray, and then blue is Native American. Again, just to set this in context, that Black Americans and Latinx patients are overrepresented in the end-stage kidney disease population. And so this really has impact. Hospice access for the end-stage kidney disease population may disproportionately impact these populations as well. So what does hospice access look like for the end-stage kidney disease population? It looks like this, and I'll tell you why. This was an excellent editorial by Vanessa Grubbs, who kind of drilled down on some of the barriers to hospice access for end-stage kidney disease. And as many of you know, when someone elects to take the Medicare hospice benefit, the hospice organization must pay for everything related to the terminal diagnosis. So in practice, this usually means the hospice organization is paying for all medical care for the patient. And so under the Medicare hospice benefit, hospices are paid a daily rate, approximately $150 per patient per day. And so unless you're operating a large hospice organization, it's pretty difficult for the cost of dialysis. So in our region, the cost of a treatment is about $300, or that's what Medicare will reimburse dialysis facilities. The $300 times 3, I mean, you can do the math, and that becomes expensive for many organizations. And there are other barriers as well, but I think one thing to point out is that only 1% of the about 4,600 plus hospices in the United States have more than 500 patients, are these so-called larger hospice organizations. And so as you can imagine, it's really hard for the math to pencil out in terms of providing for hospice and dialysis at the same time. I mean, there are other sort of issues that may come up around, some thoughts that the philosophy of continuing dialysis is does not quite match up with the hospice philosophy, but I think those are things that we've certainly been able to address. And so when you look at the end-stage kidney disease hospice utilization, it's pretty low, as you can imagine, because there are some of these structural issues here at play. So this is end-stage kidney disease hospice utilization in the 2000s compared to patients with advanced cancer, advanced heart failure. And I want to give a shout out to Dr. Susan Wong, who published this back in 2012. And as you can see here, this is looking at a variety of different healthcare utilization metrics, detailing the intensity of care during the final month of life for people who are on dialysis. And pretty much in every metric, people with end-stage kidney disease experience higher intensity of care at end of life compared to patients with advanced cancer or advanced heart failure. You can see the hospice use at this time was 20% amongst patients with advanced cancer, about 55%, and close to 40% for heart failure. And there's other data sort of corroborating this. So this was a study of about 1,000 patients from the health and retirement study, and demonstrating that patients with advanced cancer utilize hospice about 70% of the time. This was published in 2020. And patients with a non-cancer hospice diagnosis about 45% of the time. And Melissa Wachterman kind of looked at this question more recently. This was published in 2018, where she looked at 770,000 Medicare beneficiaries on dialysis who died between 2000 and 2014. And for the full cohort, 20% of patients received hospice services at time of death. It was up to maybe a little more than a quarter by 2014. I think these numbers also tell a very important story. So the median hospice length of stay was 5 days. So clearly, people are making a decision to stop dialysis, given sort of this median hospice length of stay. And 2/3 were enrolled for less than a week, and 41.5% less than 3 days, which I think some of you may recognize as a quality metric in the cancer world as an indicator of poor quality end-of-life care. And so clearly there's a lot of work to be done with respect to improving sort of end-of-life care experience of people who are on dialysis. As a part of the study, Melissa Wachterman's group also looked at healthcare utilization and cost by hospice length of stay. So I'll walk you through these figures here. So in figure A, these are measures of healthcare utilization at the end of life. And in figure B, these are the mean costs. In this light blue are patients who did not receive hospice services. In this beige, less than 3 days. This sort of light teal, 4 to 7 days. The brown, 8 to 14, and then the dark teal, more than 15 days. So as you can see here on these metrics with respect to healthcare utilization, the longer you are on hospice, the less likely you had intensive healthcare utilization at end of life, and the lower your cost. When you look at no hospice in less than 3 days, the costs are the same. There's significantly high healthcare utilization. Really, the only thing that happens is that people have a pretty, in my view, likely a chaotic transition where they're discharged from the hospital to home and then die in less than 3 days. So the bottom line here is there's a lot more work to do in terms of improving access to hospice for dialysis patients. These are summary figures that detail the relative lack of access to hospice for our patients. It's about half that of the general Medicare population, and a third with respect to hospice length of stay. And just recall that patients with end-stage kidney disease are overrepresented in terms of minoritized communities, and so it's going to disproportionately affect their access to hospice services at the end of life. And so currently, the way our sort of health policy is structured is that we have an either/or system, either dialysis or hospice care. And for many patients and families, that can feel like falling off a cliff. One of the unique features of end-stage kidney disease is the relatively short prognosis after stopping dialysis. And this is dependent on what someone's residual kidney function is, but most people who are in this spot generally do not have much residual kidney function. So you're generally looking at about a week, maybe 2 on the long end. And so right now, patients and families are forced to make this impossible choice if dialysis is helping them achieve an acceptable quality of life. It may not be, aspirational, but still acceptable. And so in our experience, it's not really been a prognostic awareness issue when people are, seriously considering hospice. It's clear to many patients and families that, yes, this is a situation where their loved one is declining, or they themselves know that they're declining. And many people do want the home-based services and expertise that hospice provides if they were to qualify. So what about a sort of a both and paradigm of both dialysis and hospice at the same time? How do we move to a model that can provide a softer landing for such a vulnerable population where there isn't this very jarring transition that can leave patients and families often feeling so unsupported? And so I think a lot about what will change policy. This is a graph taken from the Congressional Budget Office from 2020. As you can see here, it's not really going in the right direction. And I think the reality is that for health policy to change, we'll need to show not only an improved patient and family experience, but that this experience improves at neutral to lower cost, especially in today's congressional environment. And so the concern in the 80s was that concurrent care was going to cost more, but I don't think we really know the answer to that question with respect to end-stage kidney disease. It might not. Much of the cost at end-of-life care is for crisis care, and hospice is so well suited to provide crisis symptom management in the home setting. So potentially, patients who are accessing acute care, accessing care in the ICU, having intensive procedures done, those costs could be repurposed to provide better access to hospice services. So about some forays into concurrent care. So I'll present some data outside of sort of the end-stage kidney disease realm. This is concurrent care through the VA. And the VA has been a leader in many, many different respects. And for my VA colleagues on the call, you probably had some experience with concurrent care. 5% of veterans were accessing hospice in 2006. And because of this, the VA started this initiative called the VA Comprehensive End-of-Life Care Initiative from 2009 to 2012. And I'm going to present some data in the end-stage lung cancer population. So this study looked at 13,000 VA patients with stage 4 non-small cell lung cancer at over 113 VA facilities. And the question they asked was, is increased availability of hospice for veterans associated with reduced aggressive treatments and medical care costs at the end of life? And the answer to that is yes. So what they looked at here was sort of the top versus bottom quintile in hospice access. So the top quintile was 79% of decedents were on hospice. And as you can imagine, if you had sort of the best access to hospice, you were more likely to have concurrent care. So no surprise here that you're more likely to have chemotherapy and radiation after hospice initiation because you're getting concurrent care as well. Less likely to have aggressive treatments. Here they defined it as multiple hospitalizations or rather within 30 days of end of life, and other sorts of aggressive procedures such as artificial nutrition, mechanical ventilation, ICU level care, within 30 days of death. And then costs themselves were also decreased as well within the last 30 days and within the last 6 months of life. So it seems like a success. And at the same time, this is going to be a paradigm shift. So this was a study interviewing 76 clinicians and staff at 6 VAs as well as community hospices. And on the one hand, one of the themes that came out was that concurrent care preserves hope and relationships during these transitions to hospice. And it required a lot more sort of care coordination. So VA-based liaisons needed to educate outside hospices that concurrent care is possible. This is a different way of thinking about hospice care. And there are concerns just about compliance with Medicare hospice regulations, because they're, again, sort of different rules around how to implement concurrent care. Ann O'Hare and Kate Butler looked at sort of the electronic medical record at the VA for patients with advanced kidney disease. Most of these folks were not on dialysis. They had a GFR of less than 20. And they looked at 130,000 veterans with advanced kidney disease and had a random sample of 1,000 veterans and looked at their medical records for hospice mentions. And so even in the VA where concurrent care is possible, hospice and usual care are seen as mutually exclusive. Hospice was seen sort of as a last resort and not something that people would actively choose. And that care was sometimes seen as too complex for advanced kidney disease patients for hospice to handle. And so it often promoted the reliance of acute care instead of hospice. And so what about outside the VA system? This is the Medicare Care Choices model. Some people have referred to it as hospice light. This sort of a depiction of locations of hospice agencies that have participated in the Medicare Care Choices model. And so for certain diagnoses, not end-stage kidney disease, but cancer, congestive heart failure, COPD, HIV, if you had a prognosis of less than 6 months, you could get a form of concurrent care, and hospices are paid, I think it was about $400 a month. This actually paid for bridge programs to help transition patients and families to a full Medicare hospice benefit. So it wasn't the same level and intensity of hospice services, but people who participated in this were 20% more likely to enroll in the Medicare hospice benefit, with a reduction in total Medicare cost, and caregivers seem to be very pleased with the overall experience. So what about concurrent care in the end-stage kidney disease population? So in July 2019, there was an executive order to launch an initiative called AAKH, or Advancing American Kidney Health. It really sought to do a number of things to promote kidney health, including increasing access to transplantation, increasing options for patients by testing new value-based payment models and preventing kidney failure. And so one of the benefit enhancements here was concurrent care. But when you read the fine print, it becomes a little bit more cumbersome to implement. So the entity that enters these voluntary value-based payment models will have to pay for anything that the Medicare hospice benefit doesn't currently pay for. And so that essentially means that the entity, which is, it could be a range of different organizations coming together to provide better care for patients with advanced kidney disease, such as, say, a nephrology physician group, works with a dialysis provider, could work with other hospice organizations, transplant center, et cetera. But that organization that is formed would have to essentially front the money and then be paid by CMS later on. So that's been a bit of a challenge, but it is a step in testing concurrent care. What about the VA? Fortunately, Melissa Wachterman's group kind of published the VA's experience with concurrent care in end-stage kidney disease. This paper came out in JAMA in late 2022. And this was a retrospective cross-sectional study looking at about 70,000 VA decedents who also had data in the national US dialysis database between 2007 to 2016. They looked at a proportion of patients who received hospice services, could have been through the VA or through Medicare, about 26%, so similar to the Medicare population. And this was about 18,000 patients. And they just looked at, who are these people? Average age was about 75, predominantly white, about 82% white. And the median length of stay in hospice for these patients was 5 days. 5 days if they were Medicare. And interestingly, so for patients whose hospice payer was VA Community Care, it was almost 2 weeks, so 16 days. A proportion of these patients received concurrent care. And the concurrent care median length of stay was approximately the same, about 43 days overall. So as you can see, patients who receive concurrent care have a much longer hospice length of stay than those who do not. And I think the sort of flexibility that the VA provides has allowed for sort of increased hospice length of stay as well. And how did the VA do this? The VA essentially financed concurrent care by paying for dialysis, regardless of the hospice payer. It was a predominant payer, about 85% of treatments. So you see here in the dark blue, as Medicare as the dialysis payer, and they're essentially paying for very few dialysis treatments, regardless of who the hospice payer is. So this is a Medicare hospice payer, VA Community Care, and VA, I think, inpatient. And interestingly, even though the VA allows concurrent care and are not bound by Medicare hospice rules, only 6.3% of those who received concurrent care had a primary hospice diagnosis of end-stage kidney disease. I don't really know the answer to that question, but certainly it raises this question of whether patients with end-stage kidney disease or sort of a related hospice diagnosis are inappropriately being deemed ineligible for concurrent care. So hospice services, we do know through some of the VA data that hospice services are associated with some improved end-of-life care for patients who don't stop dialysis before death. So this is a survey of 3,300 patients that Ann O'Hare and Claire Richards, as well as a few others did. They looked at these patients at over 100 VA medical centers. The initial question is actually looking at the association of stopping dialysis treatments and the association with bereaved family survey rating. So initially they found that stopping dialysis was associated with better bereaved family survey readings compared to those who choose not to withdraw from dialysis. So that is the continued dialysis group here. But they looked at sort of interaction of hospice services for those who choose to continue dialysis, and this difference in quality of end-of-life care was attenuated. So these were several different metrics on quality end-of-life care. So this is excellent overall quality of care. Has always provided patient and family spiritual support, and then alerted family to patient's impending death. And so for people who choose not to withdraw from dialysis, if they received hospice services in this sort of dark blue here, they had better overall end-of-life care on these different metrics compared to those who continued dialysis but did not receive that service. So pivoting a little bit to other concurrent care models. So this is a model out of Pittsburgh. So DCI, which is Dialysis Clinic Incorporated, a nonprofit kidney health provider that serves 16,000 patients in 30 states, primarily dialysis provider, and UPMC Family Hospice, the University of Pittsburgh Medical Center, started a concurrent hospice and dialysis program. Their eligibility criteria was having a prognosis of less than 2 months based on clinical judgment. Oftentimes these patients had recurrent hospitalizations and were functionally declining. Patients and caregivers may be asking for concurrent care. And goals of care discussion to make sure that they were aligned with the program. And then they could receive up to a month's worth of dialysis. So the 10 palliative dialysis sessions is referring to 10 in-center hemodialysis sessions, which is about a month's worth of dialysis. And that could also be a month's worth of peritoneal dialysis as well. And they had sort of a dialysis champion and a hospice champion, had a palliative dialysis order set, as well as to coordinate and tailor care for patients in this concurrent care program. They just published their data in 2022, and as an aside, this paper was one of the 10 best of ASN journals. So this is the National Kidney Conference, and was highlighted as one of the best papers of the year. Who were these people that they served? So there were 43 patients. Average age was about 74, but a pretty wide range between 36 and 97. Again, predominantly white, 74%, with multimorbidity. So the Charlson comorbidity score was around 8, and you can see that all the different comorbidities and sort of the percentages here. 88% were on hemodialysis and 11% on peritoneal dialysis. And when we look at the sort of hospice utilization outcomes and the dialysis utilization outcomes, there were very few ED visits or hospitalizations, just 2 for these 43 patients. 2/3 of them died at home, none in the hospital, and the rest in either inpatient hospice or skilled nursing. Interestingly, only about half of them decided to utilize concurrent care in terms of dialysis treatment. So only half of them had at least one more dialysis treatment after hospice enrollment. Sort of begs the question of why that is. Was it important to be able to have the opportunity to do dialysis, but also to be able to say no and have that safety net? I think that's one of the questions there. But of the other half who did receive dialysis treatments, they received it for about a week and a half if they're on hemodialysis. It's 3.5 sessions, approximately over a week, and then 19 days, a little less than 3 weeks for peritoneal dialysis. And hospice length of stay, the median length of stay for the entire cohort was 9 days, and almost 2 weeks for those who received 1 or more dialysis treatments. And so what about concurrent care here in Seattle? We're very lucky here to have a partnership between Northwest Kidney Centers and Providence Hospice of Seattle. It is a sort of similar model to the DCI and UPMC model, with the exception that we're using the usual hospice criteria for entrance into the program. So as long as someone has a prognosis of less than 6 months, they can receive concurrent care through the model here. So I'm going to go show you some of the data that we've collected so far, and this is unpublished, but this is decedent data since 2017. And this is decedent data of patients who have been seen by our Northwest Kidney Center's kidney palliative care team. So they may or may not choose to access hospice. To date, we've had 226 decedents with an average age of 72, 2/3 male and about a third male, a little over a third male. And you can see the racial breakdown here, 2.6% American Indian, about 20% Asian, 20% Black, 8% Hispanic and Latino. I think this number is actually higher because of misclassification on some of the forms, and a little over half are white. The hospice utilization overall in our cohort is 44%. So, double the national average, or a little less than double the national average, but clearly, more work needs to be done there. And this is the hospice length of stay amongst our decedents for those who choose to enroll in hospice. So the mean hospice length of stay is 24 days overall, driven, I think, primarily by people who are able to get concurrent care. So the mean concurrent care hospice length of stay is about 48 days, which is similar to the national sort of VA data that had been published. Median hospice length of stay is 7 days. And for those who are on concurrent care, 37 of them, 26 days. We were fortunate to have some cost data. So Northwest Kidney Centers was part of a value-based payment model, so the first iteration, what we called ESKO 1.0. And so we had access to some Medicare cost data for our patients. So the 61 decedents that did have some cost data, we broke them down into patients who did not receive hospice, or patients who had hospice but not on concurrent care, and then patients who received concurrent care. And these are the total Medicare costs in the last 30 days of life and in the last year of life. And so as you can see here, for patients who received hospice, whether it was concurrent care or not, they had very similar sort of costs in the last 30 days and the last year of life. But seems to be less than patients who did not receive hospice overall. It's hard to sort of draw conclusions with such a small data set, but clearly there's not a very clear signal for concurrent care costing more than sort of the usual paradigm. So back to Morty, he received about 5 months of concurrent care before he died at home. And, when I was speaking to his wife, Leah, about this, she was saying there really was no choice with regard to dialysis, in that it was helping him live longer and be at home longer with her. And they were very clear around wanting to continue dialysis as long as they could. Morty himself had numerous conversations, not only with me, but with his primary nephrologist, about potentially stopping. And he always said, like, why would I do that? And so it really wasn't until he had difficulty getting to the car that they both decided to stop. At that point, he had been really well plugged into his hospice team. He died peacefully at home. And Leah actually shared her story and Morty's story at ASN this past fall. There's a real push legislatively to draw up a bill for concurrent care for patients with end-stage kidney disease. The details are still pending, but if this is something that you're interested in pushing forward, please do consider contacting your representative to support concurrent care legislation. So, in summary, the structure of the Medicare hospice benefit creates financial disincentives to provide hospice for end-stage kidney disease patients. Hospice utilization and length of stay is decreased compared to Medicare beneficiaries. Disparities in hospice access for end-stage kidney disease patients systematically and disproportionately affects minoritized communities. New payment models are testing concurrent care, and existing data suggests it increases hospice access and hospice length of stay. Concurrent care is currently available at Northwest Kidney Centers through Providence Hospice of Seattle. And finally, please do consider contacting your representative to support concurrent care legislation if this is something that's, that speaks to you. So thanks again for having me.
Thanks so much, Dan. Can you
and
see Wayne has a question and you have a couple comments in the chat?
Sounds great. Well, and I forgot my last slide. This work requires a community, and I want to first and foremost thank our patients and families. I want to give a shout out to my teammates, Megan Nolan and Jennifer Lichty, nurse and social worker on my kidney palliative care team, and want to thank the folks at Northwest Kidney Centers and Providence Hospice of Seattle for making this happen. All right.
It looks like Wayne had his hand up first, and then after Wayne, Ton.
Okay, well, thanks, Dan. This is great. And you can see there's an arc towards better access to stop this being a hard barrier of end-stage kidney disease to receiving concurrent care. So that's terrific. Thanks for your work to advance that. I was thinking, as you were presenting it, you presented some historical data from quite a while back. I started with working with Providence Hospice about a little over 20 years ago. Back then, you could a qualifying diagnosis for hospice was inanition, which is the same semantic as very advanced frailty. And then that became taboo about 15 years ago, and you had to say inanition due to what? Dementia or whatnot. And then frailty fell off the map entirely, and you had to have a diagnosis like Alzheimer's disease or cancer or what have you to enroll in hospice. But within the dementia realm, what's driving hospice utilization, costs, and to some extent fraud these days are dementing illnesses, which is a substantial portion of hospice enrollees. And it's likely to be truncated rather dramatically in coming years to avoid the costs and fraud concerns by Centers for Medicare and Medicaid Services. So it's kind of rolling back around at CMS to thinking about, well, how about if we have consensus around severe frailty and forget the diagnoses? So kind of rolling clear, full circle to inanition. But you can imagine that might work in end-stage kidney disease. In other words, drop the barrier for end-stage kidney disease. Just say, okay, if somebody's bedbound, mute, and incontinent with end-stage kidney disease, or some frailty level that had good inter-rater reliability, you can imagine you could embrace concurrent care because of frailty. That would pertain to a small fraction of people on dialysis. Of course, it becomes harder to dialyze people when they're that frail, right?
Yeah, you generally do not see people at that stage, but those are probably the folks who are, if you are able to, you know, physiologically dialyze them, these are probably folks that would fit the less than 2 month category. And I think that there are concerns around, you know, the longer stay patients. As you know, like prognostication is challenging, period. And while from a patient and family standpoint, it's great if I certainly wish for people to be able to graduate. That's a bit of a challenge when we're saying, you know, someone is on hospice for, say, 7 months as opposed to 1 month. And so I do, while it sort of breaks my heart, I do think that if something does get passed, I think there will be a prognostic cutoff that is different for patients with end-stage kidney disease. It's still better than nothing, and so I would certainly still be a proponent of that. But I do like your idea, Wayne, that maybe there are other ways in which we can, redefine sort of shared conditions that end-stage kidney disease patients may benefit from. All right, who's next?
Ton?
Hey, thanks, Annie. Hey, thank you, Jen, for presenting this. I have two questions. So the first one is kind of based upon my prior work as a medical director in hospice too, is that this issue kind of took care of itself for the most part because of people's functional status, is that once people got so frail and so debilitated that they could not transfer or sit up to a chair to receive their HD treatment, that was kind of where it stopped. Do you know, within this the data that you presented, was there any idea of what people's functional status was? That's my first question. And my second question, in these examples of the concurrent care, how many of these organizations were nonprofit versus for-profit, looking at specifically at the VA, and like within your data set? Yeah. So within your data set that you did not publish yet, I assume that those were all these organizations that you have on this slide here. And so all those are nonprofit, but within the VA concurrent side, like how many of those were for-profit versus nonprofit side?
Yeah, that's a great question, Ton. I don't think that, Melissa Walkerman's group was looking at a pretty large data set. So they broke it down. I can go back and check, but I don't think they actually looked at nonprofit versus for-profit. It was broken down by Medicare versus VA access to hospice. So they're looking at sort of the hospice payer, not necessarily like the for-profit or nonprofit status. And that may explain some of the sort of qualitative data around the range and some of the barriers that people have faced around advocating for concurrent care in the VA system. Because, you may have a great relationship with one community hospice who sort of understands what concurrent care is all about, and then with another, it may just require a lot more sort of education and care coordination. So, and Ton, you'd also asked another. So in terms of the hospice agencies that our team has utilized, I would say it's like 99% was Providence Hospice in Seattle for concurrent care. There were early on when our team was we're just trying to do right by our patients and try to get them access to hospice. And so we were trying to work with a number of different agencies to do this. And some people were able to sort of pay out of pocket. So there were some patients who accessed other hospice organizations, but it's just a smattering of patients. And did you have one other question? I may have forgotten it.
It was just related to the patient's functionality.
Oh, yeah. I don't think it was drilled down to the degree that you like, but certainly the patients who entered sort of the DCI family hospice, they have a prognosis of less than 2 months. And so they're likely to be very frail. There's also like a nursing facility, I think, that's attached to, I think, UPMC family hospice. And I think there are patients who, like, there's a dialysis facility in that nursing facility. So, there are probably patients who had pretty significant frailty. But the patients that you're talking about in terms of pretty severe frailty, I think some of those patients will stop, but then there is this sort of set of patients who don't stop and then who end up in the hospital setting. And I think concurrent care may help address some of the end of life care needs for those patients.
And And then you have Barb and then David.
Hi, Dr. Lamb, what a great presentation. Thank you so much. So I'm Barb Hansen. I work with the Washington State Hospice and Palliative Care Organization. So I work with all the hospices around the state. And I would venture to say that any hospice would support concurrent care because it would get rid of all of those dilemmas about deciding what's palliative treatment and what's life prolonging or curative treatment. So it would just eliminate a lot of those. But I just want to also point out that it's not one of the barriers, of course, is the cost of dialysis, but it's also everything that might be related to the patient getting dialysis. That's a cost barrier. So most hospices in Washington State get about $200 or slightly over $200 a day for the first 60 days of hospice care. And if the median length of stay is 5 days, so you're looking at about $1,000 of payment. And then I don't, most patients getting dialysis maybe 2 to 3 times a week. And I don't know what the cost per treatment is, but if they require lab work, the hospice would have to cover that. If they have a problem with their shunt, wound care issues, hospice would have to cover that. If they need a Medivan to get to dialysis, hospice would have to cover that. So out of that, $1,000 average, most hospices around the state are probably in the 50 to 75 average daily census range, and they don't have the revenue to support taking dialysis patients. And it's such a huge dilemma because I think this is a patient population that just doesn't get access to hospice like they should. So again, thank you for the presentation.
Yeah, absolutely, Barbara. I couldn't agree with you more. And I think that's why the fix here, we have some demonstration projects, but the real fix is a legislative fix. And, fortunately, there is some momentum here. I think this is work that you're just going to have to continue to persevere through. But I do think the real question I think that Congress will be looking at if they take up this bill is this going to be cost neutral or not? And I think that it is not clear that it will cost more. In fact, sort of our, again, very, very limited data suggests there's no signal that it's going to cost more. It certainly could, and I think that's part of the reason why the prognostic eligibility may be different, unfortunately, for patients with end-stage kidney disease. And one thing that has helped, at least in terms of the DCI and family hospice, sort of, well, I guess I don't know exactly how their contracting is, but I will say that from NKC and Providence Hospice of Seattle's contracting, it is essentially a bundle. So there's certain things that like Providence won't have to worry about around certain medications and labs and that sort of thing. And those are things that, we would be asking the question, like, is it really appropriate to be continuing to check labs or, certain medications that are expensive, like calcium mimetics, like they're probably not really going to be affecting someone's long-term health and certainly symptom management as well. So, yeah. David.
Yeah, thank you. So very quickly, just wondered if you could give us a peek at the kind of language you would use in discussing concurrent care with your patients.
Yeah, I just want to acknowledge, and this is probably similar to how people may approach hospice conversations. I just describe hospice. I describe the kinds of services that people can get at home, that they have a full team of, nurses and social workers and, home health aides. And I know other things have kind of fallen off the map with the pandemic, but just being able to sort of describe the kind of infrastructure that hospice provides in terms of acute symptom management, 24/7, nights and weekends, being able to go in the home and address symptoms and contrast that with what they would otherwise access, calling 911. And sometimes people have already experienced this, like yeah, I mean, it's not like my loved one was comfortable or that I was comfortable when the medics came. They didn't really know what to do in terms of symptoms. And I think in describing that, you know, and acknowledging that there is this, that hospice can be a laden term for people. I think many people are very open to that. Like, oh, I would love that service. What is that called? And then you can sort of, there's an openness to address some of the other concerns that people may have around, well, will I get as good care, et cetera. And I think one other thing that I've added is that this is a service that traditionally has excluded people with end-stage kidney disease. And so framing it from the perspective you're getting more, which is the truth, I think is helpful and helpful for communities that have distrust with the medical system, where they've experienced discrimination within our health system.
Thank you. That's great.
I don't know if there are other questions in the. Oh, I see Jennifer DeRosa has a comment. I want to give a shout out to Jennifer DeRosa. She is one of the liaisons with Providence, who has been seeing a lot of patients with concurrent care as well. Many, many, many thanks to you.
Yeah, you have a number of great comments in the chat, Dan. I recognize that we're a little over time. One of the questions too was whether or not you knew the names of the bills that people can call and advocate for, or
it's not written just yet. So there's Representative Blumenauer in Oregon is, I think, leading this charge, and you know, I think there are a lot of behind the scenes conversations. So I think that if you write to your representative and say, I hear that there is legislation being considered for increasing access to hospice for patients with end-stage kidney disease, that would be great. Thank you so much for that question.
thank you very much.
Well, it was wonderful to see everyone. Thank you again for having me.